Good morning. Good morning to everyone, and welcome to today's conversation hosted by Compassionate Ottawa. I think it's our third conversation. Bonjour et bienvenue à tous. My name is Monica Patton, and I am the chair of Compassionate Ottawa. Compassion Ottawa s'efforce de tout nous inciter à nous préoccuper des autres afin que tous les membres de notre communauté puissent vivre, mourir, et faire leur deuil en toute dignité. Compassionate Ottawa works to encourage all of us to care for others so that everyone in our community can live well, die, and grieve well. Today's conversation is all about that, how healthcare, social services, and the community can work together to achieve those outcomes for all of us. Two wonderful leaders are with us today to talk with each other. I'm going to introduce Nick Busing, and he will introduce Julian Abel. I hope you've read Nick's professional pedigree. Professor Emeritus at Family Medicine at Ottawa University, retired president of the Association of Faculties of Medicine, a beloved family doctor here in Ottawa. He's a Compassionate Ottawa Board member and serves on several other boards as well. Now that's the formal stuff, at least some of the formal stuff. I know Nick in a very different way. I know that he is a compassionate neighbor and a compassionate friend to many. I know that he has an unswerving focus on his family, which includes 2 kids and 5 wonderful grandchildren. I know him to be a great uncle, and I know him to be a great brother to 5 siblings, of which I am one. I'm so happy that my brother Nick agreed to talk with Julian Abel today, and I'm going to turn it over to you now, Nick.
Well, thank you so much, Monica, for that very, very kind introduction. And I want to begin by this conversation by welcoming Julian to our conversation. Julian, so delightful to have you, and we're very much looking forward to chatting together. I thought I would begin by asking you, well, I was going to ask you just a little bit about your story to date, how you got to be such an advocate for compassionate communities and your background, and I will ask you that. But I thought should ask perhaps why you were sitting in a car to do this Zoom visit with us, because that has quite a story to it. So welcome, Julian, and over to you.
Thank you. And I thought I might say that, of course, I do all my conference calls from my car, but it's not actually the case. The local electricity board where I live in Cornwall has decided that today was a really great day to take one of the telegraph poles down and replace the electricity transformer and the line, which has meant that that the electricity in our house and therefore the internet wasn't working. So my solution was to drive to the local supermarket, which is maybe 10 miles from my home, so that I get a good reception signal on my mobile phone and that I can talk to you all, which just makes the background slightly strange.
Great. Well, yeah, that is somewhat unusual, but your reception is great. So tell me a little bit about yourself. What's been your journey to get to where you are today?
Well, my clinical life was as a palliative care physician, and I worked for 15 years as a palliative care consultant in a hospice and a local hospital, doing work in the community and in hospital and hospice. And about a decade ago, I had this kind of brainwave. It's surprising when you think about it because it's so obvious. But thinking, I'm working with patients and I'm doing my utmost to control their symptoms and keep the family informed, and just trying to be as holistic as possible. And just one morning, it was like I'm missing the point, and it was like, it's all about the people we know and love in the places we know and love. And that just completely led me down the route of compassionate communities and the public health approach to palliative and end-of-life care. and you know, obviously the next step is you know, as it happened, Alan Kelleher was working nearby, and we met at a meeting, and then we met at the Public Health Palliative Care International meeting in Limerick, and we just got on, you know. It's like an old buddy, you know, a similar approach, and it just grew from there. And I then ended up organizing the international conference in 2015 in Bristol. I then became vice president, with Alan being president of Public Health Palliative Care International. And then we worked out that actually we could very easily write papers together. That seemed to be a good partnership. And then we just wrote papers and plotted, and that's really continued. And I've got involved in all kinds of different programs, a whole variety of different levels. And so it's just been a increasing interest.
Well, that's just wonderful. And let's just jump right in, because one of the things that you do now, I know very actively, and I'm particularly interested in, is what I colloquially call your Froome project, which was a project which really brings clinicians, family doctors like myself, together with the community. And I've read your book, The Compassionate Project, and I've looked at your BMJ article, and that particular study shows some remarkable outcomes. So I wonder if some of our audience will know the study, but many of them won't. So could you just outline it, provide us the details, how it got started, how it evolved, and talk a bit about some of the outcomes, because I think they're highly relevant.
I'd be delighted to do that. And I've got a few slides. And I'm going to just show these slides just to give a bit of background. And the way that I phrase this is really to say that it's all based on compassion, and because compassion lies at the heart of social relationships. You know, that if you think about, you know, the people who you're friendly with, the people that you love, it's because they're kind and compassionate. And there are 4 really good reasons to think that compassion is fundamentally important. And the first is this fantastic study by Julian Lundstedt and her colleagues, relationships on reducing our risk of dying. And for those of you who want to hear more from Julianne, that I interviewed her on my podcast, Survival of the Kindest, which you can find on the Compassionate Communities UK website and on Apple Podcasts or wherever. And it really is understated, this slide. But she found a way of measuring it. And it turns out that social relationships, the heart of which is compassion, are more effective at reducing our risk of dying than giving up smoking, drinking, diet, exercise, and anything else we care to mention. And I include down the bottom the red bar, because that's a drug treatment of high blood pressure. And social relationships are more powerful at reducing they absolutely dwarf the impact of treatment of high blood pressure in terms of keeping us alive, never mind keeping us healthy. And when you look at the impact of loneliness and isolation, what you see is that the figures are remarkable. If you're lonely and isolated, you've got a 30% increased risk of dying, in having a heart attack, increase of stroke. And if you've already got a disease, then you've got a massive increased risk of dying and increased risk of going to hospital. And amazingly, a 50% increased risk of getting dementia. And there's a fantastic study in the US that's gone on since 1938, looking at the lives of men in the first instance, measuring them every year up until the current day. And the 4th study lead, Robert Waldinger, concludes that if you want to stay healthy and happy, it's all about warm relationships. And George Valent, the 3rd study lead, says it's all about relationships. And you can ask why this is the case. And the reason why the impact of social relationships is so profound is because it's built into our evolution. And it's not just human evolution. In fact, it's all animal evolution, including vertebrates. And even for those people who want to see something amazing, you can watch a film called My Octopus Teacher, and you see this octopus make friends with the guy who made the film, and he gives the man a big hug at one point in the last contact he has with him. And so actually, the phrase survival of the fittest is couldn't be more inaccurate. And survival of the kindest is how we manage to find ourselves all over the earth, and we help each other out. And so kindness, social relationships are an evolutionary pressure, particularly in humans, the most social of animals. And when you look at it from that perspective, then it's no surprise that if you put the compassion at the heart of a population-based intervention, and you link that with healthcare, you get profound outcomes. And we were really surprised to see the outcomes of reduction in emergency admissions in Frome over a 4-year period across the whole population of 15% at a time, where in the county of Somerset of 500,000 people, it went up by 30%. And there are no interventions ever that have reduced population emergency admissions. This is like some kind of magic that you pull out of a hat. And it's a whole, so I'm not going to go into too many details, but basically that the way that this works is thinking about how you change primary care, about what you need to do inside the GP practices to bring social relationships into the routine clinical setting. And there's a variety of different interventions that you need to do that, and you'll find the details of that in the book, in the Compassion Project, and including which, when you're thinking about what you do in the community, or there are 4 major things that you do in the community. The first is about mapping all the stuff that goes on in every community, and this is highly relevant for Compassionate Ottawa, because you're thinking about how can you access a community resource. Well, you make a list and stick it on an easily accessible website, and then you form groups, and again highly relevant for Compassionate Ottawa, because you can think about peer support, bereavement groups, and other kinds of carer support that go on in the community. But you can have things like talking cafes for people who are lonely, etc., etc. And the next thing you do is you can think about you've got the groups, the talking cafes, the resource. Well, why not just train people to know about stuff that's going on in the community? And that's the formation of the community connectors, who are activated community members. And it can be absolutely anyone, can be, hairdressers or cafe owners or policemen or receptionists, or if you know what's going on in the community, because of the natural kindness of people, then when they hear a conversation about stuff that's going on in the community, they will naturally link people up, whether it's through a talking cafe. And the last bit is the one-to-one work of the community the health connectors, who are people who are trained in motivational interviewing. And you tie all of that together, and then you get the outcomes.
Yeah, that's what I wanted to just pursue a little bit, because I'm always interested in the methodology that have been employed when I read these studies. So just expand a little bit on the health connector. And what I'm challenged with. I'm a retired family doc, but I have lots of active family docs. How do we get started? I mean, tell us a little bit more about how you bring a family doctors, primary care communities together with the community. It just doesn't happen like that. So talk about that a little bit for me.
So we use the Institute of Healthcare Improvement Quality Improvement methodology to bring about change, which essentially means that change has to be at the hands of the people who do the work, which is absolutely critical, because you have to fit it into working practices. And that means that if you open the domain of social relationships and compassion as a subject of discussion, you have to have something that's you can easily do to address those issues with people. And you have to remember, this is done within the context of a 10-minute consultation in a GP surgery. And so that you basically have, if you ask a question about people's social welfare, and there are different ways of doing that, you can say, look, if you're feeling lonely, this is all the stuff going on in the community. We've embedded the service directory into the clinical record to make it easy for the doctors to use. Or you might say, look, you're pretty down in the dumps. You know, it's quite a big thing for you to even know what's going on. So I'm going to get you to see one of the health connectors who can talk about what's going on with you and actually direct you to what you want. And probably the easiest way to see how this works is to describe the case of Kathy, which we talk about in the book. And Kathy was a businesswoman who got in her early 50s, who got severe rheumatoid arthritis. From being an active family member walking a dog, she was in a wheelchair within the space of 3 weeks. And she went to a doctor and said, look, I need to have a sense of hope. And it would be really good to meet other people in similar situations. And the doctor said, well, I don't know exactly how to do that, but I do know somebody who can help you. So Rob, the doctor, sent her to Rose, the health connector, who came to visit Kathy in her home. And Rose says, I've got just a thing. And she sent Kathy to the chronic disease management group that happens in the health center. And of course, they met Kathy with open arms. And she went through that program, went into an exercise program, and then went into exercise groups in the community, and then became a community connector and became an incredible advocate. And Kathy's conclusion is that the friends that she made were the thing that made the biggest difference, that she became connected into her community. And with all the health giving benefits of the oxytocin and the hormonal cascades, they don't just make you healthy, they protect you from disease. And she says that the friendships were deep, and I know that I am there for them and they are there for me. That sense of connectedness, which is so powerful and so emotionally strong, actually transformed her life. So it's about making the changes inside primary care teams to make it easy for this to happen, and have community development situated in the meetings in general practice.
Right, no, well, that's very helpful. So before moving on, I had a couple of other very sort of, practical questions about your Froome study. The data that I read was from 2013 to 2017. So I have two questions. One, do you have a newer data with regard to the admissions? And secondly, has Froome yet been replicated, duplicated elsewhere? Because frankly, it's a study which I would be very excited about trying to launch with colleagues here in Ottawa. We wanted to hear what your experience is so far.
So we don't have data, and there are complex reasons for that. And some of those are political, and some of those are to the enormous difficulty of getting access to data, particularly in the UK. I'm sure you're all aware of GDPR, and access to medical data is really tricky and really closely guarded. So we only have data going up to the end of 2017. But with regard to other projects running, we extended the project to the whole of Mendip, which is an area. Froome is a town of 28,000 people, Mendip 115,000, and we saw improvements in Mendip. We started up projects in South Wales, two projects in South Wales. One is more mature than the other, and prior, to the pandemic, they were beginning to show signs of admissions reductions and reduction in use of the emergency department. We've got a project starting in Colombia and in Florida, and another project starting in London. And I mean, things got massively disrupted by the pandemic.
Right.
But we've had interest from all over the world, and a lot of interest from Scandinavia, and people hoping to start projects up. And one of the things about compassionate communities is that they work anywhere. Community development is a tool that is useful all over the world. And what you're basically using is the fact that human beings are naturally built to be compassionate. We are naturally evolved to be compassionate. And when you make use of that, the effect of it is absolutely transformational. So you can do this anywhere and everywhere.
So as I mentioned earlier, I'm a family doctor in Ottawa, a community of over 1 million people, over 1,000 family doctors. They may practice in fee-for-service, they may practice in groups, they may be salaried. So where do I begin? I want to know, how do I begin to think about and create a Froome-like model in my community?
Well, I think that the simplest route is actually to have a conversation with us, and we've worked out an implementation model. And Compassionate Communities UK will help you run programs, have a mentoring and advice service, and because it does need investment, but and it needs a methodology of change, and trying to do it just on your own is a big ask. And we know that you have to implement the whole model to really be able to get the benefits of admissions reduction, but it's much easier to learn from what's gone on before. And we've done this in single GP surgeries to large practices. And as long as your methodology is a participatory one, in that you put the control of change into the hands of the people who do the work, and that includes community members.
Absolutely.
Yeah.
Yeah. So that would be the challenge. And I'm certainly not thinking of me wanting to do it alone. I just wanted to get a framework about where we could begin. But I hear you clearly that we could have a further conversation about that. So let's that's fantastic. And as I said, I was particularly impressed with your results. Let's pivot a little bit and talk about something else, which I know I'd be interested in. And that's the Compassionate City Charter. I think we have a variety of people that are participating, many of whom will know about your Compassionate City Charter, others may not. And in particular, I was impressed that you've introduced a new number to this Compassionate City Charter, which talks about neighborhoods and local communities and so on. Can you expand on that a little bit and tell us about the Charter and tell us about that?
Yeah, so where all of this stuff originally came from was from Alan Keller here, who applied the principles of public health to end-of-life care to really start thinking about what are the interventions that you need on a population basis that actually return death, dying, loss, and caregiving into communities, rather than just thinking this is a medical issue. And so he used public health methods and terminology to try and implement these programs across whole geographical areas. And that developed into the Compassionate City Charter, which looked at, so death, dying, loss, and caregiving, actually, nobody escapes that. Everyone is involved, and therefore the impact is on everyone, and the impact is everywhere. It has impact in schools, in workplaces, in educational institutions, in religious institutions, in communities and neighborhoods. And actually what you're doing is making best use of human beings' natural compassionate potential, which is to help each other out. Now, we added in the compassionate communities in at a neighborhood level because I think perhaps we'd made an assumption that it was kind of obvious, but what we're doing is creating compassionate communities everywhere in workplaces and educational institutions. There's like the advantage of having the 13-point program is it allows people to come together to deal with it in a systematic way, that if you go through and build in all of these areas, you can have population-wide change in all of the environments. But the heart of it lies in creating compassionate communities, and in particular, how we look out for each other at street and neighborhood level, about, the people around you. There's a big thing in Britain that we're stiff upper lip and we like privacy. And so you don't look over the garden fence and see how your neighbor is. And we say, look over the garden fence. It's really important to know how your neighbor is.
I particularly like that addition. when I joined and teamed up with folks in Compassionate Ottawa, frankly, for me, one of the important visions right from the beginning was that neighborhood vision. How do we support the person next door? And I often used examples. I've said, well, somebody 2 doors down has somebody who's dying or who's unwell. And frequently we don't know how to support them. We don't know how to go and knock on the door. We don't know how to lend our support. And I've always felt that at that level, it was particularly critical and important. So I'm a big fan of the addition you made, and and because we've worked in Compassionate Ottawa at a number of critical levels, like in schools, faith communities, workplaces. But I think bringing it down to the neighborhood is critical. And certainly one of the issues we have in Ottawa, as we have worldwide, is dealing with street people, marginalized people, those who are drug addicted, living on the streets and so on. And we have to get into that community. So I think this is a wonderful addition. The other thing it brings up for me is, how does this relate to, and how should we think about the COVID pandemic, which we're in the middle of? And this is a critical issue for everyone, but how's compassionate communities? How are we going to help try to address this and help relieve some of the suffering?
So we talk about the principles of this in the book, and we say in particular that compassionate imagination is key. Our ability to recognize the suffering in ourselves and the suffering in others, and having the desire to relieve that suffering. And then if you've got a compassionate imagination, then you think about putting that to good use in whatever circumstances you're in. And that's all about communication and about the different ways of communicating. And that whilst we have limited social and face-to-face contact, there's lots of things that we can do, which might be, if you're in strict lockdown like we are in the UK, then maybe it's just dropping a note round to the neighbours, or doing what we're doing now, using Zoom or Teams or whatever it is, or WhatsApp, or calling people up, or talking to people through windows, or meeting up when it's safe to do so, socially distance outside. And that when you start to use your imagination to do this, then it's amazing. And we've seen incredible examples of it, actually from all over the world. I mean, there's some that I really love is when the first lockdown was our strictest, and people would perform stuff in the streets to keep the children amused. They could look out the window and see what's going on. I remember it was a fantastic thing from a housing estate in Ireland, and there was this done from the roof, and everyone on the estate went outside and danced to music, socially distanced. It was absolutely great. And when you think about the different ways that we connect with each other, it is really about finding ways of doing that. And Frome Town Council, for example, came up with a program of look after 5 neighbours. Everyone should check out their 5 neighbours. And you can then start to build compassionate streets and neighbourhoods through doing that. So it's really a question about, using your imagination to connect with people in whatever way you can.
Oh, sorry. Yeah, I think we lost you. You okay?
Can you still hear me all right?
Okay, I'm sorry. I thought we lost you. Yeah, no. So that's helpful. Let me ask. Let's explore compassion a little bit more, because I know you've written about compassion, and you have kind of a view of how you would define compassion and how it impacts. I'd like to hear a little bit more about that perspective from you.
Yeah, sure. I mean, I think as human beings, particularly as people from Eurocentric Western origins, we like to compartmentalize things. But the reality is that we don't neatly fit into compartments. We don't have emotions that we can define and say, this is what this is, and it doesn't affect anything else. It's just that one thing. So compassion, in a sense, is an inclusive phrase rather than an exclusive one. And on a very simple level, that you can think that, you know, like I was saying, you recognize your own suffering, you know that other people don't want to suffer, other people want to be happy, and that the compassion arises and it motivates you into action. But that action is imbued not just with all of the things that we know that go with it, such as empathy and other descriptions, but it's also imbued with kindness. And so they're like compassion and kindness are like two sides of a coin, that they go together. And you know, it kind of manifests in all kinds of different ways, in all kinds of different actions, you know, whatever people feel capable of doing. And I think that the other thing that's really important to remember is that every human being has the potential for compassion, because it's part of our evolution. And we also have choice. And you know, it's one of the things that we hope to do with the book, is to inspire people to be more compassionate than they already are in small steps. And the starting point for that is to recognize that you're already compassionate, and that when you make someone a cup of tea, when you have an act of kindness, when you feed your children first, where you talk to somebody when you go down the shops and you just have a nice time, that these things, that we swim in a sea of compassion and we often don't see it. So the starting point is to recognize that you are already compassionate and see it all around you. And then you can start taking small steps to increase it further. That it's really not something we have or have not. It's there and we can make it grow. We're not stuck with who we are. We can change.
Yeah, and no, that's, I hear you. That's a challenge sort of to draw it out, because I certainly accept your premise that we all have that within us. But the challenge is how to encourage the compassionate side of us, for want of a better words, to take hold and move forward. And you're going to do some things, I believe, relating to compassion. There's going to be a summit with regard to compassion. Can you talk a little bit about that, the summit you're planning?
Yeah, so the book has been, the Compassion Project's been published in North America, and I thought, well, why don't we, you know, do something around the book? And I started to talk with some amazing people in Canada and the US, and we, from this kind of simple premise, it's turned into an Elevate Compassion Summit series, and that will be, you know, there'll be be done via the internet, and it will start in June, but there'll be a monthly seminar series going on the back of that. And what we really hope to do is to draw together all the amazing stuff that's going on about what versions of compassionate communities that don't carry that name, but there's lots of organizations across North America that are doing this work. There's an incredibly proud history of community development, and it's you know, can we come together as a group and act as really powerful advocates to elevate compassion as a value that's high up in our list of priorities? And can we do it across a nation? Can we do it across a continent? You know, this is absolutely critical for our survival. Compassion was critical for our survival forever, and when we're coming out of the ice age, and it's going to be even more critical now as we face the future. So it's about trying to inspire everyone to become more compassionate.
You know, I think for folks like me who've lived in a sort of a medical environment all my life, my professional career, and have some sensitivity to the incredible importance of community development. But I'm a novice at it, so I need to hear from somebody like you. So tell us a little bit about strategies for community development, because I think that is critical to building this relationship, which is part of our theme today.
Okay, so one of the bits of magic of community development is that when you gather people together, they will naturally get on with each other and determine what Cormac Russell describes as who leads asset-based community development as what's strong, not what's wrong. That's your starting point. Is, you know, you have to build relationships and trust, and then you can figure out, you know, what's good about your community, and then you can start to figure out what are the things that need to be added to it. And I would say that the community building is about what's called the associational life. It's about not being done to, but being done with. And that the people who are best defining what needs to be done are the people who have the lived experience of it. And you know, there are some technical things that you can do to stimulate that process. And in particular, in the, you know, in what's happened in Frome, there are some other things which really help, like some of the infrastructure around building community connectors, about people who know what's going on in the community, about community builders, about people, what are the structures you need that will help people to come together? And there's some technical sides of that, but you can look at some fantastic examples. And, you know, a highly relevant example is, how did Stacey Abrams in Georgia manage to really get so many of people who've not voted before to vote? You know, and interestingly, you know, that the ABCD Institute started in Chicago with John McKnight, and Barack Obama was a community development worker under John McKnight. And so the whole thing about building communities from the ground up and making sure that you start with what's strong, thinking about the associational life, and thinking about how you can apply that in different places, relying on the natural compassion and cohesiveness of people. That's how you build communities. And of course, that can take place. Communities are wherever there are people, and that includes your workplaces and your, you know, et cetera, education institutions, et cetera, et cetera.
Yeah. No, that's very helpful, and that gives my sort of my mind a bit of a framework to move forward. I want to go back to, I was very impressed with your slide about social relationships. So I wonder if you can expand on that a little bit more. Social relationships is sort of as a public health issue, and the challenges for that, and how important that is. I think that's critical.
Yeah, I agree, and you know, there was an interesting quote that Julianne Holt-Lundstat had paid attention to, going back into the 1980s or something crazy like that, where somebody had said that, you know, that social relationships are a public health issue at least as equal to other risk factors for disease. And, you know, and that's proved to be the case. And I don't think there's been any recognition in healthcare that that this is a tool that you can use clinically. And actually, when you, I think part of the reason for that is really around the pharmacological pressure that there is in medicine, and without necessarily considering the biological impact of human relationships. But I think we're in a different place now. And I think that now it's a time where we can say, look, if you want to use the best medicine, then actually your most powerful therapeutic tool is social relationships, way and above everything else. And that is really about, in a way, education, about the recognition of, you know, how does that work on a biological level? You know, how do you explain that? And it is very explainable. When you look into the biochemical pathways, the hormonal health, the psychological aspects of it, the social aspects of it, the evidence is now overwhelming. And I think we are at the dawn of a new era of medicine. I think we'll see this field expand because not just because the impact of it is so profound, but when you hear the stories of how it changes people's lives, it's so heartwarming. It's so encouraging, and it seems to place us in that sense of being connected to our community and the people around us, which for whatever reason we've lost. And I would just add to this that on Survival of the Kindest, I interviewed Holly Prince, who is a student of Mary Lou Kelly, and they both worked in First Nations communities in Canada. And Holly described it so well. When she first came across Compassionate Communities, she came to that conference in Bristol in 2015. She said, wait a minute, this is what we normally do in our First Nations community. And she described that sense of kinship. And kinship isn't just with your family members. Kinship are the people around you and the place, the ground on which you walk, the air that you breathe, the food that you eat, the animals that are there, the vegetation that's there. The kinship is with our whole earth. And I think that what, it's the interdependence of all of that together which makes a difference, and that's what Compassionate Communities is doing. That's what social relationships do, is that they embed all of that into our lives, and we've become separated and lost from that. But this is a refinding of who we are as human beings.
One of the things which, amongst many transformations that's occurring because we're in the middle of a COVID pandemic, is the delivery of healthcare. It's become increasingly virtual. Technology is becoming more prominent in this era, before COVID and even more so during COVID. So my sense is, okay, how do we, in that environment, which in some senses puts distances between people, how do we preserve, how do we enhance compassion in the context of virtual visits, which more and more doctors and nurses and others are doing, in terms of technology, when we have remote ways of doing things and so on? How does compassion fit into that? Or how do we make sure we keep compassion in that environment?
Well, I think compassion is about context, and it's about the quality of human relationships, and I think what we're saying is that that therapeutic intervention has to be embodied with compassion. And then it's about then recognizing the importance of social relationships, and you can ask simple things like, who do you have friendly chats with? Who do you turn to in times of need? And because those questions begin to explore if you like, the compassionate social domain of people's experience. And you can do that face to face, or you can do that, you can do it virtually. I think it's really there's like the Zoom and the Teams and the WhatsApp, where you see the person, is actually very helpful, because then you get tone of voice and you get, physical posture, like, for example, such as me squashed up in the seat of my car, but there's loads of cues that we are really sensitive to, that we can pick up on and actually begin to make some emotional assessment of what's going on. And when that's imbued with compassion, that actually does come across through talking to people, through tone of voice, through posture, through hand expressions, etc. And it's making sure that quality is present all the time.
So you think we can achieve that in the new virtual reality, to put it that way? I think there are challenges. I mean, I guess, again, from my family medicine background, that relationship in person over time was critical. I hope was critical to me, and I hope was critical to my patients. And I'm just struggling to make sure that we don't lose that.
I completely agree, and there are significant limitations of the virtual. we have to do what we can with what we've got. And, you know, all being well, you know, that we will get on top of the pandemic and we can start meeting each other again. And and I would say that I hope that that what the pandemic has done is to highlight the real importance of social relationships, the real importance of our connectedness, of, you know, as Mary Lou and Holly say, is our interdependence, not our independence.
The other theme that I know you have, I think I've heard you talk about, and is highly relevant, even more so in COVID, is the concept or the theme, the reality of loneliness. And I wondered if you wanted to make a couple of comments about how in the, you know, in the COVID environment, the challenge of loneliness is critical. And to me, that's one of the really fundamental issues which compassionate communities need to deal with: the isolated senior, the lonely person, the person on the street. What do you say about that?
So I think that the important thing to remember is that someone is lonely if they feel lonely. That it's not just to do with physical isolation and separation. That you can be lonely even in the context of being in a crowded room. And you can have many friends and still feel lonely. And so that the actually the important thing in the context of compassionate communities, including from the medical perspective, is ask about it, is be sensitive to it, pick up on the cues. You know, we are incredibly sensitive human beings. We have this incredible facility to imagine the experience of someone else. So we can ask about it and not be judgmental about, oh, you've got lots of friends, lots of money, you're beautiful, therefore you're not lonely. It's just not the case at all. And it's about saying, okay, let's build communities. Let's not be judgmental. Let's look at what connects us rather than what separates us. And let's talk about it. Let's use our senses to know whether people are feeling lonely or not. And let's create community spaces. And and that might be just a talking cafe where people can go to chat. It might be, you know, I was hearing on the radio this afternoon, they were talking about bereavement, and the radio presenter he asked a mate of his whose dad died. He said, tell me about your dad. And his mate spent the next half hour pouring his heart out, describing this person, describing his father and how much he loved him. And it's about that kind of sensitivity, about our connectedness. In a way, another way of thinking about this is, you know, that we tend to think of human beings, you know, in the same way that we think about our cardiovascular system. You know, we have our heart and this thing functions, and we have our lungs and that thing functions, but it just doesn't work like that. We are integrated wholes. And what we don't see physically are the social connections, the things that connect us to different people. But they are there. That web of interconnectedness is there the whole time. And if you like, that relationship web, which is imbued with the quality of compassion and kindness, is the thing that we really have to concentrate on and work with. So if you stop seeing separated individuals and think about the connectedness of all of us, then that becomes a place of action.
So I think we only have a few minutes left. I want to shift gears entirely. I want to talk to you about, in a lot of my career spent in medical education. And one of the tenets that we promoted, particularly in Canada, but worldwide, was around the social accountability of medical schools. So I want to link that back to ask you about the education of physicians and the education of nurses and other healthcare practitioners. And how do we start to introduce into the curriculum some of the concepts, some of the realities that we've talked about today, because I don't think that they play any prominence in our curriculum in medical schools today. So what are some thoughts about that and some strategies?
So I think that you can look at what's happened with the historical development of palliative care. You had Dame Cicely Saunders in the hospice in the 1960s and saying, oh my God, we're missing something here. We need to pay attention to the whole person, to their physical, social, psychological and spiritual suffering. And that was, and that influenced the whole practice of medicine. That actually being truthful to people is a good idea, talking about what's going on and working not just with the person, but with their family. But at the same time, what we've seen, and you saw how palliative medicine was introduced through research, through talking about it, and then through education, and then through development of a specialty and curriculum. And we're in the same place now with public health palliative care. And next year we'll see the publication of the Oxford Textbook of Public Health Palliative Care. And I think that will be a foundation document for moving away from a medically dominated, cancer-dominated model of end-of-life care into providing education. We've got in the training curriculum for palliative care specialists in the UK about thinking about this broadened approach, which brings into context compassionate communities, social relationships, etc., etc. And we are at the beginning of that same process for the whole of medicine. That we are going to have to go through that whole cultural change, which means that we need to pay attention to doing the things of presenting the information, doing the research, writing books and papers about it, about having the conversation about it, providing practice examples, building structural programs, strategic programs about this, and then embedding it into the education curriculum. And that's going to take 20 years at least.
Is any of that happening now anywhere? Can you give us some pointers?
Yeah, I think that when we got the results, when we saw the emergency admissions data from Frome, we were flabbergasted and astounded. And so we began the process of, we wanted to make these results available to people. And actually, one of the most effective things we did was get publicity about it. And that stimulated worldwide interest. And then what happens is that there's increasing interest. It's not just to compassionate communities. There's increasing interest in social relationships and mortality and morbidity. And then you look at the evolutionary stuff, such as the stuff coming out of Brian Hare and Vanessa Woods at Duke University. They've written a book called Survival of the Friendliest. You got the Rutger Bregman stuff about humankind. And what you're seeing is a change in attitude to this. And we're hoping to draft a paper called Medicine Reimagined, where we actually start to put the case of saying, look, medicine needs a big rethink. And in particular, we need a rethink about what pharmacology means. And, there's a very big question about clinical trials, because if social relationships are so profound, the highly symbolic, powerful relationship of doctors cannot be standardized, because when you conduct clinical trials, there is an interaction between human beings, often repeated. And the quality of that interaction is often more powerful than the medication. And this gives a big question mark about the methodology of the double-blind placebo-controlled trials. It's an area that needs investigation.
Well, that's another long conversation, which I'm sure we have significant opinions about. I want to loop right back to earlier on, and I want to explore a little bit more, ask you to. I think in the Frome study, the development of the community person, the health connector, was critical. That was one thing that I noticed. And the other thing which was critical, which can be a challenge in many communities in Canada, is that the the family doctor isn't always as connected to the hospital as the Froome folks were. So I wanted you to expand a little bit about how do we think about this community connect? I know you've talked about it a bit more, but I want to tease it out a little bit more, and also challenges with our hospital structures.
Okay, so the community connector, so the health connector, the people who do the one-to-one work, are people who are not health professionals, but they're trained in motivational interviewing, and they're good at drawing out what's bothering people, what they want to achieve, about setting what is it they would like to do, and then helping them achieve that. And for people who need the help and support of that, you don't need a don't need like what's going on in the community and how to connect you up. Is that they actually initially they employed nurses to go into the hospital to help with the discharges, and so one of the key components is about the free flow of face-to-face communication between siloed organizations. So you have to figure out about, okay, how are you going to do that, and how do you arrange it with your multidisciplinary team meetings? And everyone is really used to doing it virtually now. It's very possible to do that, and it's a conversation that makes a difference. And the difference is really remarkable. And so if if you just take Ontario, if I'm not mistaken, it's the size of France, either just northern Ontario. The distance are huge,
Right.
and so you have to figure out what are your communication channels, and you have to make sure that those communication channels are secure and regular and frequent, because you need to have the conversations across organizations. And organizational leadership is really important here, because often health and social care organizations get caught in perverse incentives. And what you find is that keeping people in hospital might be good for social services, but isn't great for hospitals. But I would add, it's really worth listening to the experience of Mary Lou Kelly, who developed a disseminated palliative care program across this huge geographical area to skill up people in the community to do the things that you can't do face to face because of the distances. So there are lots of models for this. And again, it comes back to creative imagination.
Good. No, thank you that's wonderful. I mean, we've had such we've covered many bases very quickly. I'm looking to Paula to know if we have any questions that Julian and myself would be willing to tackle.
Yes, we do. Thank you so much to both of you. This has been absolutely a delight to listen to. And I wish we had more time, but we do have quite a few questions from our audience today. So the first one says, the project is sometimes called the Froome Project and sometimes Health Connections Mendip. Can you please clarify how these organizations are structured and work together?
Okay, so the way it worked was there's this great GP, Helen Kingston, who is full of common sense and down to earth but visionary, and she moved into the large medical practice of Froome and thought, well, I want to provide the best service for people, and being supported by the community. So she employed Jenny Hartnell, who's a community development worker, from within the medical practice, so that the community development side of the town was linked directly to the medical practice. And Jenny could attend the multidisciplinary team meetings, and it grew from there. At the same time, Froome Town Council, I mean, it's kind of a unique place, Froome. Like Froome could be any town, and the principles can be applied in any town. It could be your town, but at the same time, it was a fortunate coming together of circumstances which allowed the model to flourish. And Froome Council were involved right from the beginning, and it's partly because it so happened that Froome Council are a fully independent council, that there are no political parties represented on the council. So people At the council participated because they could see it made common sense. So it was about developing a coordinated vision of different people together, the breakdown of siloed organizations, and a way of drawing everyone together. And Health Connections Mend It was the community development arm. The Froome model is the combination of the changes that happened inside the primary care team and the community development side of it in the town and within. Does that answer it, Paula?
I believe that it does. I think we lost you for just a second at the
Right, we
very
did.
end there. Would you be able to repeat just the last couple of sentences that you said, Julian?
So the Froome model is the combination of the changes that happened inside the medical practice combined with the Compassionate Communities program that happened in the town of Froome. It's the two things together. Health Connections Mend It is a community development arm of the project.
Yeah, I think we're going to have to be creative in Canada to be able to duplicate Froome in terms of its political or non-political structure and so on. And I think we have communities the size of Froome where we could think about it, or we have practice groups which would have 30,000 patients in them we may have to work with. We have to think in those terms. Over to you, Paula.
Thank you, Nick. So the next question comes from one of our viewers on the YouTube live stream. They ask, how do we bring people together during the pandemic restrictions when many have low-tech literacy and or access?
Yeah, it's problematic. And I'm sure Nick has got some ideas about this because you live in Canada. But it is about, you know, for goodness sake, check on your neighbors. And if you're going shopping, give them a call and ring them up and say, you know, I'm going shopping. Is there anything you would like? You know, or just, you know, if you live close by, just check on them, knock on their door, see how they are. Whatever way you can to communicate. It's about how we look after each other. Nick, but what do you think?
Yeah, no, I mean, I agree. You have to get out there and again, what public health folks say is wear your mask and stay 6 feet away. But that does not preclude us from reaching out to these people about low tech, who have low tech environments and so on. And I think that means people that are isolated, people are living in boarding homes, people on the street, people are neighbors. We can still do some of that communication without needing the technology. And I think, frankly, I think it's probably more important than it ever was because these people are suffering even more.
Great, thank you. So the next question reads, I'm struck with the parallel between the use of community resources with lived experience to develop and run compassionate communities and the use of persons with lived experience as mental health peer supporters. In the latter case, there are training options available. How much training is needed for folks involved in compassionate communities?
So I think that, you know, with when there are kind of specialist areas where the need is greater, a bit of training can help. But actually, you know, it's what happens along the way that makes the biggest difference. It's and we've seen this so many times, actually, that when people come together, if they're in a good space together, you know, whatever it is, it might be a common interest, it might be a talking cafe, it could be meeting down the shops, it could be going for a walk with each other, the men's shed, doesn't matter. If you have that common interest, that common space, it happens by itself. It's who we are naturally. People naturally want to get along, and if you've got a shared interest, then that makes it easy. And I think that, you know, that the peer support model and the community models that are present in mental health have been around for 30 or 40 years, and they're great examples. And you know, likewise, you know, somebody had made the comment about community clubs and groups. They're all part of the same thing. It's just a compassionate communities is a label for doing what we do normally as human beings. And it's about seeing the importance of that and allowing it to flourish.
Thank you. So the next one reads, how do those who have been involved for generations in providing community social services or organizing community clubs and groups view compassionate communities? Do these already organized entities play a part in the development or evolution of compassionate communities?
So I think there's a really important point here, and and it's really worth emphasizing that this is not starting from afresh. The starting point is what you already have. And this is a very greedy initiative in that it incorporates everything. And the more stuff that there is, the better. So that means that all the stuff that's gone on with community building is all part of it, and that's your starting point. And then it's about actually developing it from there. So that the key is not the label, but it's the heart behind it and drawing it all together and making sure that you can make the best use of it. So I would say that those people who've done all that work are natural community builders, and that should carry on. What do you think, Nick?
Yeah, no, I would agree. I would describe it in terms of the importance of compassionate communities like Compassionate Ottawa in building partnerships. I think this is a, Compassionate Ottawa as an example is hoping to be a value add to those existing services out there. So the key in my view is to go out to those organizations, talk with them, and collectively work together, because I think together we will be even stronger. This is not an environment where we are trying to supplant or we need to recognize what's out there and we need to build on it. And that's a partnership kind of model.
Thank you. So the next question comes from another YouTube Live viewer. What sort of relationship have you found between compassion and trauma?
So trauma happens. It's inescapable, and there's both physical and mental trauma. And the after effects are very individual, and the key is around how you deal with that. And that you can think of this in terms of bereavement, and I'd refer you to the work of Samar Aoun, who has done groundbreaking research in this area, and she's has shown clearly that the most effective form of bereavement support is peer support, and that's about compassionate listening. And so that the impact of trauma, the emotional impact of the effect it has on us, is profoundly affected by compassion. And a great example of this is again I spoke with Walid Nassif, who is now lives in Canada, interestingly, and was somebody who grew up in Iraq and was an interpreter in Baghdad. And if you want to hear about trauma, listen to Walid's experience. And his comment was, "It's never too late for compassion," which I think really sums it up. So I think that it's intimately linked and vitally important.
Yeah, I would only echo what you just said, Julian. How critical in those environments, traumatic environments, compassion is. I think that's a given. Yes.
So the next question says, in many years of doing community work, focusing on the strengths of people achieved the best results. Do you have a comment on this?
Yes.
Yes.
But there's something to add to this, actually, and it relates to asset-based community development, and Cormac Russell points this out really well. But it's not just Cormac Russell. You can look at the work of John Knight, Peter Block, etc., etc. It's that actually, as professionals, we tend to identify deficits. We see where the problems are, and then we think the solution is by solving that problem. And the classic example of that, for me, is about symptom control in palliative care, whether symptoms are physical, social, psychological, or spiritual. And we have a tendency to think that if we just control those symptoms, then that will give people happiness, and it's not the case. The happiness comes from the things that are most meaningful and most valuable in life. And that's the people we know and love in the places we know and love. And the symptom control helps, but it doesn't give us that happiness. And so it's about really paying attention to the really important things. And the important things are the strengths. They're not the deficits. And if we pay attention to that and recognize that every single human being is full of strengths, is full of this wonderful treasure of compassion, and we should make use of that. And strengths is that you don't want to belittle people and make them feel small. You want them to feel confident and heartfelt that what they're doing is great things.
Yeah, no, I would fully support and agree with that. And I think frequently the challenge is that we often address an issue and go to the problems and go to the difficulties. And I think we need a mindset where we build on, everybody has strengths and every environment has strengths and positive aspects of it. And it's critical that we build on those and that be our focus forward, rather than saying, okay, we have all of these problems, how do we solve them? I think we will solve those problems by focusing on the positive and the strengths.
Wonderful. So the next question from our YouTube live stream says, what are the research priorities and evidence that we need in the next 5 years to advocate for compassionate medical practice? For example, policy, intervention, etc.
So it's a great question. I think prospective evaluation of areas that implement their own version of the Froome model, so that you can watch the changes that take place. And that evaluation has to be both qualitative and quantitative. You know, the stories are really important, and there are measurable things that make the difference. I think there's a whole host of other investigations and questions that have arisen about current medical practice and how it's evaluated, and thinking about the impact of social connectedness. And interestingly, it's something that Julian Holt-Lundstad has been wrestling with a long time, is about thinking about interventions that make a difference. And you know, she's been part of a 4-week intervention using something called Nextdoor, which is a way of connecting neighborhoods up. And even in that short space of time, it has an impact on the happiness and the lives of the people involved. And I think it's going to be a slow process, you know, but it's going to be have increasing momentum. And the work has to be done. And I would say that, and this is mildly controversial, I think that, or probably not mildly actually, research evidence is a narrative. That what's happened to research, you know, it's very, very different from the very fundamental principles which were easy to apply perhaps 200 years ago. It's become incredibly complicated, politicized, and in many cases biased. And but nevertheless, it's something that the scientific community believe in, and evidence has been given this kind of importance, which I don't think is quite justified. And you know, to go back to, I can't remember who said it, but evidence of absence is not absence of effect, or evidence of effect is not, I can't remember what it is, but basically saying whether we can show evidence or not doesn't mean that the evidence isn't there, that the effect isn't there. Yeah.
So I'd like to thank everyone for all of your questions. Unfortunately, we have reached the end of our question and answer period, but thank you so much to everyone. And I would like to turn it over back to Monica Patton for some closing remarks.
Okay, well, I am not sure where to begin, and I'm going to keep this quite brief. First thing I want to say is we have never had a guest, a conversationalist, from a car. And I don't actually know how tall you are, Julian, but I can only imagine how much you are looking forward to, unscrambling yourself from being in your car. And we're very grateful that you went out of your way to do it the way that you have. I know Nick is in the comfort of his office, I believe, and doesn't have that excuse. I just have to tell you, my head is full. My heart is full too. You have offered, both of you have offered such extraordinary insights to us. I've written down so many phrases. I'm not going to recite them all, but what I'm going to do, what I am going to cite is, we are naturally built to be compassionate. And you said that, Julian, in many ways, several times, and I'm going to hang on to that, and that could become a mantra for Compassionate Ottawa. So I also want to say to people who are listening that, and encourage people to download that podcast. It's called Scarcity of Kindness.
Survival of the kindness.
I'm sorry?
Survival of the kindness.
Excuse me, survival of kindness. And I have listened to several of them, including Mary Lou Kelly's that was referenced by you, Julian. Survival of kindness is well worth listening to when you're on a long walk or doing whatever you're doing when you listen to podcast. I'm also going to follow and see when the Global Compassionate Summit takes place. I think that we will be very, very interested. Compassionate Ottawa and many people on the call today will be very interested in that. So thank you both so very much. Nick, thank you for bringing the Ottawa reality, but beyond that, this sort of the Canadian reality to this conversation as well. You are all going to be asked to complete a feedback form, which will be, I think, arriving right after this. And the session has been recorded. So you will be able to see it again. It will be on our website. You'll get that information from Paula and Jenna in our office. So with that, we'll let you know when the next conversation is going to be held. We're in planning that at the moment. So we look forward to everybody signing in once again for that. And in the meantime, Nick and Julian, you have inspired us, and we are all going to carry your message as we go about the rest of our day. So many thanks to both of you.
Thank you. And I'm really delighted at the opportunity, and also the fact that the mobile technology held out from the car.
Yeah, that's wonderful.
Exactly.
That's great, Julian.
Bye to everybody.
Goodbye, everyone.